Hello and welcome to this learning module. Today we're going to discuss the EMS response to emergencies involving the endocrine system. This video is intended to supplement any readings or coursework assigned by your instructor. Upon successful completion of this learning module, students will be better able to differentiate type 1 and type 2 diabetes, identify and treat hypoglycemic emergencies, and list assessment and treatment of hyperglycemic emergencies. The endocrine system is made up of glands that help to regulate many body functions. Glands secrete chemical substances called hormones that have their effects on different organs throughout the body. Hormones are carried by the bloodstream to all parts of the body and affect things like physical strength, mental ability, growth and development, voice pitch, and behavior. Good health is dependent upon a well-balanced output of hormones. The hypothalamus is a structure deep within your brain. It's the main link between the endocrine system and the nervous system. The hypothalamus keeps the body balanced in a state of homeostasis. The hypothalamus receives chemical messages from nerve cells in the brain and from the body via the peripheral nervous system. The primary function of the hypothalamus is to react to the messages to keep the body in a state of balance. Just like you may have a smart control system to seamlessly manage all the functions in your home, the hypothalamus is our body's smart control coordinating center. The hypothalamus helps manage body temperature, blood pressure, hunger and thirst, sense of fullness when eating, mood, sex drive, and sleep. The pituitary gland sits just below the hypothalamus, and it consists of two lobes called the anterior pituitary and the posterior pituitary. The hypothalamus sends signals by releasing hormones to tell the anterior and posterior pituitary when it's time to secrete its hormones. This image illustrates where the various endocrine glands are found throughout the human body. The pancreas is an endocrine gland that secretes the glucose-regulating hormones insulin and glucagon. The pancreas is also a digestive organ because it makes enzymes that help with digestion. The islets of Langerhans is the region of the pancreas where insulin and glucagon are produced. The islets comprise about 2% of the pancreatic tissue but receive up to 15% of the pancreatic blood flow. The islets are made up of beta cells that produce the hormone insulin. As we all know, glucose is a major source of fuel for our body's cells, so maintenance of glucose levels is crucial for normal cellular function and ultimately normal body function. Some cells can get away with using fats or protein as energy sources when little or no glucose is available, but the brain cells cannot use anything but glucose to function. Brain cells cannot make glucose, nor can they store glucose for more than a couple of minutes. So the consequences of a lack of glucose to the brain cells for even a short period of time will cause brain cell dysfunction and ultimately changes in the patient's mental status. The normal blood glucose or BG range is 70 to 120 milligrams per deciliter. When a patient's blood sugar drops below normal levels, this will result in altered mental status. Prolonged low blood glucose levels will lead to brain cell death. Subsequently, too much glucose in the cells will cause water to enter the cell, which can cause swelling and other complications. When a patient's blood glucose level gets too high, the glucose will be excreted through the kidneys and urine, and that will bring the water along with it, leading to dehydration. With normal glucose regulation, after we eat a meal, our blood glucose rises and the insulin is secreted from the pancreas. The insulin allows glucose to enter the cell, and the liver creates glycogen, which can be stored for later use. When the blood sugar drops below a certain level, glucagon is secreted, which causes the liver to release glycogen to produce glucose and increase blood sugar levels to a normal range. This image shows how insulin attaches to a cell and unlocks the cell membrane so the glucose can enter. Without the insulin to unlock the cell, the glucose molecules are unable to enter the cell and remain in elevated levels of the blood. As I mentioned earlier, the hormones insulin and glucagon work together to regulate blood glucose levels in our body. Insulin has three main functions. Number one, it allows for the movement of glucose out of the blood and into the cells. Number two, it causes the liver to take glucose out of the blood and convert it into glycogen, which is a stored form of glucose. And number three, it decreases the blood glucose levels by moving the glucose out of the blood and into the cells and liver. A glucometer is a device that samples a drop of blood and will calculate the patient's blood glucose level. A normal blood glucose level runs between 70 and 120 milligrams per deciliter. The image on the left shows a glucometer that will analyze the small drop of blood and provide a reading in under 6 seconds. You'll learn how to use a glucometer in lab. Some patients who have diabetes may wear a device that continually monitors their blood glucose levels. This device is called a continuous glucose monitor, or CGM, and is shown in the image on the right. The small round sensor monitors the glucose level and transmits the information to the owner's cell phone or receiver. This can also communicate with insulin pumps that can adjust the insulin delivery based upon the CGM readings. Under normal circumstances, the hormones insulin and glucagon regulate blood glucose levels. When a diabetic emergency occurs, it's due to an abnormality in this control over the blood glucose. Diabetes mellitus, known commonly as diabetes, is a condition where there's a disturbance in the metabolism of carbohydrates, fats, and proteins. There are two types of diabetes. Type 1 happens when the pancreas fails to make insulin, and type 2, which happens because the cell receptors are unable to recognize the insulin and allow the glucose to enter the cells at a normal rate. As a result, blood glucose levels become elevated and continue to elevate as a result of continued glucagon secretion. Type 1 diabetes is commonly called juvenile onset diabetes because the peak ages for onset are 4 to 6 and 10 to 14 years of age. Patients with type 1 diabetes are unable to produce insulin in their pancreas. This is caused by an autoimmune disorder where the body attacks the islet cells that make the insulin. Patients with type 1 diabetes need insulin injections to control their blood glucose levels. The image at the bottom of the screen shows a vial of insulin that must be injected using a syringe. The image on the top of the screen shows an insulin pump that connects directly to the patient and administers insulin as needed. Type 1 diabetes patients are at risk for diabetic ketoacidosis, or DKA, when their blood sugar levels become extremely elevated. We'll talk more about DKA shortly. The pancreas of type 2 diabetes patients does not produce an adequate amount of insulin, or their body has become resistant to the insulin that is being made. Either way, there's not enough working insulin to allow the glucose to leave the bloodstream and enter the cells or liver. Type 2 diabetes tends to happen later in life. Onset usually occurs in middle-aged individuals who tend to be overweight. Recently, however, we've seen an increase in juvenile onset type 2 diabetes due to an increase in overweight children with poor nutritional habits. Treatment for type 2 diabetes usually includes a regimen of diet, exercise, and oral medications. In patients who are extremely insulin resistant, injectable insulin may also be added to the patient's treatment. A type 1 or type 2 diabetes patient who requires insulin may be referred to as insulin dependent. Unlike type 1 diabetes patients, patients with type 2 diabetes are not prone to DKA. When their blood glucose levels become extremely elevated, they experience a condition known as hyperglycemic hyperosmolar syndrome, or HHS. We'll also discuss this condition in a few minutes. Hypoglycemia can happen in both type 1 and type 2 diabetes patients. Hypoglycemia occurs when a patient's blood sugar drops below 70 milligrams per deciliter. This can happen in patients who take their insulin but forget to eat a meal, or in patients who take their insulin and eat a meal but increase their activity beyond normal. This happens frequently in children. Hypoglycemia can also happen when a patient takes too much insulin or gets confused and double doses their insulin. Oral medications taken by type 2 patients can also cause a drop in blood sugar. The brain needs a constant supply of glucose to continue to function normally. When blood glucose levels in the body drop below normal, patients will usually experience an altered mental status that can include confusion, disorientation, drowsiness, or unresponsiveness. As the blood glucose level drops, epinephrine is secreted at higher levels. The effect of the epinephrine is to shut down secretion of insulin and stimulate secretion of glucagon, which in turn converts stored glycogen into glucose. As a result, many of the signs and symptoms seen in hyperglycemia are associated with the epinephrine circulating in the body. Hypoglycemia occurs suddenly over a period of several minutes. Signs and symptoms include skin that becomes diaphoretic, cool, and pale. Patients may also experience tremors, dizziness, and stomach upset that is attributed to increased hunger pains. While blood pressure remains at a normal range, the patient will experience an increase in heart rate, while respirations will remain normal or become shallow. If blood sugar drops extremely low, the patient may experience a seizure. Hypoglycemia can also present with unilateral weakness, facial droop, and slurred speech, as we would expect to see in a patient having a stroke. Management of hypoglycemia for a patient who has an altered mental status but remains responsive and able to swallow includes ensuring a patent airway, assessing the blood glucose level, and administering 1 tube of oral glucose. When administering oral glucose, never put your finger in the patient's mouth. Spread the oral glucose on a tongue depressor or bite stick and place it in the patient's mouth between the cheek and gums with the glucose gel facing the cheek. This will be readily absorbed through the mucous membranes of the cheek. As the patient becomes more alert, they will be able to take the tube and self-administer the remaining contents. If you have a patient with a history of diabetes who presents with an altered mental status and you are unable to obtain a blood glucose level, you should administer oral glucose if the patient is conscious, able to swallow, and able to maintain their airway. For patients who are unresponsive, unable to swallow, or unable to follow commands, we need to ensure that we maintain an open and clear airway, as well as adequate ventilation and perfusion. Supplemental oxygen can be administered to a saturation of 94% or greater. We can assess the blood glucose level, but should not attempt to administer oral glucose to a patient who is unresponsive or unable to swallow. Advanced life support will be able to initiate intravenous access and will provide glucose through their IV. Placing the patient in a recovery position can facilitate drainage of any secretions. Elevated blood glucose levels, or hyperglycemia, can lead to a condition called diabetic ketoacidosis, primarily in patients with type 1 diabetes, or hyperosmolar hyperglycemic state in patients with type 2 diabetes. The 3 most common signs and symptoms of hyperglycemia are called the 3 P's of diabetes. Polydipsia, which means that the patient is increasingly thirsty. Polyuria is a condition where the body urinates more than usual and passes excessive amounts of urine. And polyphagia is the medical term for excessive or extreme hunger. Here we compare the 2 different types of hyperglycemia that can happen in patients with diabetes. Diabetic ketoacidosis, or DKA, occurs primarily in patients who have type 1 diabetes. Hyperosmolar hyperglycemic state, or HHS, tends to happen more commonly in patients with type 2 diabetes. With DKA, the type 1 diabetes patient's blood glucose, or BG, is usually elevated above 350 milligrams per deciliter. Because there's a lack of insulin to move the glucose into the cells, the body begins to burn fat to create ATP. The byproducts of this process include ketones, which are acidic. Signs and symptoms of DKA include unresponsiveness, deep and rapid respirations, and a fruity odor on the breath. The signs and symptoms that accompany DKA are caused by a combination of the dehydration and acidosis that occurs from the process. DKA is a slow onset that may progress over a few days. With HHS, the type 2 diabetes patient's blood glucose level can range anywhere from 600 to 1200 milligrams per deciliter. Most glucometers will be unable to read the glucose levels of this elevated and will simply read HI or high. Type 2 diabetes patients experiencing HHS do not develop the ketoacidosis that accompanies DKA, so their respirations usually remain normal and they do not have the unusual fruity odor on their breath. These patients do, however, excrete large amounts of glucose and water in the urine, which can lead to life-threatening dehydration. You may hear HHS called hyperosmolar hyperglycemic nonketotic syndrome, or HHNS, because these patients do not develop ketoacidosis. This slide compares the signs and symptoms of DKA in type 1 patients to HHS in type 2 patients. The onset and progression of both conditions is slow and occurs over a period of a couple of days. Patients will present tachycardic and hypotensive. Patients will also be polydipsic, polyuric, polyphasic, and experience GI upset and vomiting. Since DKA presents with acidosis secondary to ketone production, DKA patients will present with a deep and rapid respiratory pattern called Kussmaul respirations. Their breath will also smell sweet and fruity, similar to the acetone smell in nail polish remover. DKA patients usually complain of significant abdominal pain that is not generally seen in patients with HHS. Please take a moment to pause the video to review the information in this table. The treatment for hyperglycemic emergencies includes evaluation and maintenance of airway, breathing, and circulation. Supplemental oxygen should be administered to maintain a minimum saturation of 94%. In patients with inadequate breathing due to Kussmaul respirations, assisted ventilation using a nasopharyngeal airway and a bag mask device with supplemental oxygen may be required. All diabetic emergencies have the potential to be life-threatening and should elicit a paramedic unit response. Patients who have diabetes will often wear some form of medical alert identification. There are different types of medical alert identification beyond the old silver bracelets we're used to seeing. Medical alert ID can include charm bracelets, pendants, anklets, temporary tattoos, and tags that are laced into a child's shoe. Also remember that folks with a mobile device may have their emergency information stored on their phone. The image on the top left shows a silicone medical alert bracelet commonly worn by younger children. Insulin is usually kept in the refrigerator and may come in vials or as pens, which we can see in the image on the top right. If you suspect a patient may have diabetes, check their fridge for the insulin. The bottom two images show two different insulin pump delivery systems. If you come across these devices that are connected to a patient, simply ask a family member to suspend the insulin delivery. Do not attempt to pull the insulin delivery devices or sites off the patient's skin. The adhesive used to secure these delivery systems is very sticky, and you may cause damage to your patient if you try to pull them off. The device on the bottom left is an Omnipod pump that is a self-contained and waterproof pump. It holds a 2 to 3 day supply of insulin. The bottom right image shows a pump site that is connected to tubing that supplies insulin from an insulin pump. If necessary, this type of delivery system can be disconnected from the site on the patient's body. Usually this is not necessary because the amount of insulin being delivered by these pumps on a continual basis is extremely small. So this brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, consider going back to review any content that you might have struggled with. Thank you for watching this learning module.